for inviting me to speak about pediatric spinal deformities, which is a very wide field of possible etiologies, diagnostics, and therapy. And if you only consider that there are about 400 syndromes, known syndromes, which can be associated with spinal pathology. So to ease the whole thing, you can break it down to this classification system, which comprises early onset spine deformities, which by definition are detected before the age of 10, which comprise congenital malformations, idiopathic deformities, syndromic deformities, and neuromuscular deformities. And the second big group are neuromuscular deformities, and of course, frustrating enough, the biggest group are the idiopathic adolescent scoliosis, which consists of about 80% of all spinal deformities detected during growth. And it's not an exotic deformity, it's not rare. If you look at girls, at the group of 16-year-old girls, about every 50th girl, 2%, have scoliosis. Per definition means a lateral curvature of more than 10 degrees. And about every 200th has a deformity which potentially needs a treatment. The main risk factors are the amount of deformity, the cup angulation, and of course, number one risk factor is growth. You see a typical scoliosis career starting with a minor deformity at an early age, at the age of 8. Between 8 and 10, there is not a lot of growth left. So there is little progression, but then suddenly at the onset of puberty, there is a rapid progression from 50 to almost 80 degrees within 3/4 of a year, which warrants further treatment. And if you look at the 3D appearance, it becomes clear that there is a wide variety of possible deformities. And scoliosis is not only a lateral curvature, it's a true three-dimensional deformity. So if you look clinically at the patient, you really need to appreciate all dimensions of deformity, and you also need to include the shoulder level. You need to include the thorax morphology, the pelvic morphology, and the lower extremities. So to detect a scoliosis, the easiest way is to let the patient bend downwards and to put your scoliometer on the rib hump. If there is a rib hump of more than 5 degrees, the probability that there is a structural scoliosis is almost 100%, and you need to make an X-ray or to refer the patient to a specialist. And there is some correlation between the amount of rib hump and the amount of deformity. And as a rule of thumb, if you have a rib hump of, let's say, 10 degrees, you can multiply it by factor 3, and you can estimate the cup angle. So 10 degrees rib deformity means around 30 degrees cup angle. In the lumbar spine, the factor is 2. So if you have a lumbar prominence of 5 degrees, there is a lumbar scoliosis of about 10 degrees. And the rib hump is associated not only to the rotation of the vertebral body, but the more significant the scoliosis becomes, the more inherent rib deformity you have. So there is an angulation of the rib thorax also. And in association to the growth law, the Hütter-Volkmann law, on the concave side, there is high pressure. So there is minimum growth on the inner side of the curve. And as a consequence of that, you have secondary deformities with a typical inflection point in the middle of the vertebral body. So this is not a congenital deformity, it's a secondary growth effect due to the deformity. And one of the reasons why many of those scolioses go undetected is the sagittal profile. Usually we have many referrals because the patients look like that, typical Scheuermann patient. But those scoliosis patients, they undergo increased anterior growth, which leads to flattening of the sagittal profile. So they look like ballet dancer, they look healthy, and that's why they are overlooked. So how do we treat those patients? If they have a deformity of more than 25 degrees, so between 24 and 40 degrees, and there is a lot of growth left. So before the onset of puberty, Richter sign 0 to 2, it's a typical and classic indication for brace treatment. And brace treatment is typically successful between 20 and 40 degrees because you put transverse forces on the spine. If there is more deformity, more than 50 degrees, you would need axial load, axial distraction to correct the spine. And this is not feasible. You would need to put a Milwaukee brace on, which is not done in mid-Europe anymore. So this is a typical indication. So when it comes to a deformity of more than 40 to 50 degrees, there is a considerable risk of further progression, a typical indication for a spinal fusion to halt progression and to correct the deformity. Within the last 30 to 40 years, there has been a shift of paradigm from happy to survive during Harrington's time in the late 60s and early 70s, where there was only a look at the coronal plane, to a three-dimensional understanding of the spinal deformity, and also patients who want to have a 3D correction of their spines and also of their shoulders and of their rib hump. So if you look at the Lenke classification, which implicates a three-dimensional understanding of the spine, you look at the cup angle, you look at the pattern of deformity, you look at the shift of the L-spine, of the lumbar spine, away from the central sacral vertebral line, and you look at the sagittal profile. And then you need to look at the patient three-dimensionally, anterior and posterior, and you need to have a clear strategy how to correct the three-dimensional deformity. The patient is not happy if the X-ray looks like that, but the shoulder is still high. So you have to make sure to include the waistline, the pelvic position, to correct the rib hump, and to correct the shoulder deformity. This can be done usually by an easy posterior procedure, if there is enough flexibility. If there is more and rigid deformity, like in this young girl with a Marfan syndrome, you need to add posterior osteotomies to correct the spine, or you need to include preoperative halo traction, or if you even have more deformity, like this girl with a 130-degree adolescent idiopathic scoliosis. And this is not a picture from Africa, it's from Switzerland, 2015. If it comes to a rigid deformity like that, you need to include halo traction, you need to go anteriorly to release the discs and the ligaments, you need to include osteotomies before you can correct the spine. And if you have a fused spine with a huge deformity at a young age, you need to perform a vertebral column resection where you free the whole spine around the spinal cord. Neuromuscular scoliosis, reason number one all over the world is cerebral palsy, and the story is completely different. You have pelvic obliquity, you have loss of sitting ability, you have pain. Idiopathic adolescent scoliosis usually is pain-free, but in those patients you have costopelvic impingement, you have rubbing on the pelvis, and this creates pain. They are usually osteoporotic, the spine is collapsing, and usually it's a rigid and severe spine. And indicated before the head lies beneath the pelvis, as in this case. Operated before the cup angle goes after or more than 60 degrees. If the cup angle is more than 60 to 70 degrees, the risk profile is changing and you have much more complication. It's often complicated and difficult to convince the patients and the parents, but it's worthwhile to prevent complications. And the goal is brace-free, stable sitting, pain reduction, and to also enable the patient to communicate again. If they have a severe deformity, they fall forward, they lose eye contact, and they lose the last resort of communication. And with a stable upright spine, also transfer functions are easier for those patients. And it's crucial to include other disciplines, anesthetists, pulmonologists, intensive care specialists, right from the beginning. It's not a problem to straighten the spines operatively, but you have a high complication rate if you don't include other disciplines. So it's like a weather report before the operation, and they put the light to red, yellow, and green for you. And don't forget, in a neuromuscular scoliosis, there is a mortality intra and post-operatively of 0.5% if you are not well prepared. The orthopedic variables, they differ from adolescent idiopathic scoliosis. You have to be prepared. If you have a patient with severe hip contractures, you have to be there to position the patient on the table. You have to have a special spine table with a frame to position the knees. You have to be prepared if there are some pumps inside. You have to be prepared if there are missing pedicles or very small pedicles in small bones. And you don't overdo it with your sagittal corrections. We are very powerful to correct the sagittal profile. It's not worthwhile in those patients because usually they have a loss of sagittal balance. They have a very poor head control. So this 5 kilo head is pulling forward. And if you correct too much, it's disrupting, it's dislodging your instruments, or it's leading to a PJK, to a proximal junctional kyphosis. So don't overdo it. Don't be too eager. Bend your rods into kyphosis. And we also prefer to end with a soft landing with hooks instead of rigid screws to provide a soft transition from the instrumented to the non-instrumented area. And we also like to put some traction, some asymmetric traction on the patient. There you always have almost full correction, and you can also almost only pop in your rods and your screws, so you don't have to manipulate too much during the operation. So this is an example of a still ambulating CP patient who is on the verge, on the edge to lose the walking ability. We made some halo traction before the operation, some posterior osteotomies, and could bring the head back in the middle of the pelvis, and this is what counts. So let's talk about iliac fixation. Strive for maximal width, so for MV tactics. Don't use too long screws, because in many of those patients you have to perform a hip reconstruction later on. And if your screws are too long, you interfere with the chisel of your colleagues who need to make a pelvic osteotomy. So you have to have a distance of 2 to 3 centimeters from your tip of the screw to the joint. And biomechanically, on the lateral view, the tip of the screw has to be anterior to the promontorium to provide maximal stability. In many of those very meager, skinny patients, this screw head can be prominent. So one alternative is to use a SAI screw, which starts medially to the ilium and goes through the sacroiliac joints through the teardrop figure. So you don't need any connectors, you don't need to dissect as much, and you don't have any implant prominence on the lateral side. But be aware of the fact whenever you go to the pelvis, you have longer OR time, more bleeding, more infection, more implant prominence. So you have to think to stop at L5. If L5 is deeply seated and horizontal, you can think about stopping at L5. One special issue is to get a fusion, a solid lumbosacral fusion in myelomeningocele patient, because there you have a lack of posterior elements, and it's difficult to gain fusion from the lumbar spine to the ilium. So here we prefer to put autologous tibia strut grafts in with a direct connection from the pelvis to the lumbar spine. So let's talk about the difficult field, early onset scoliosis with a very high variability, many comorbidities, about 30% intraspinal pathologies, tethered cord, syrinx, diastematum, myelia, and so on, and a bad natural history. So in many of those young patients, they have a very high mortality if you don't treat them. So it's easy to treat them, or to get an idea how to treat them if you differentiate between an abnormal vertebral anatomy and a normal vertebral anatomy. If it's mono or oligosegmental, you can think about performing a vertebral resection, a hemivertebral resection, if there is a high risk of progression. For example, if you have a medial tethering, or if you have a combination of a hemivertebra and a unilateral bar, you have a high progression rate and you need to perform a hemivertebra resection. But if you have a mono or polysegmental problem, and if you have a progressive curve in a very young one, as in this 3-year-old with a 70 to 80 degree curve, You can try to control the curve over years with serial plasters. So like in Ponseti treatment for club feet, you put serial plasters on in anesthesia and you buy time. About 10 or 15 years ago, we were very enthusiastic. We operated very early, but it leads to a lot of complications. So nowadays, we gain time, even if it's only 3 to 4 years, it's better for the patient. But what if the curve is progressive, even under brace treatment, even on the serial plaster, if you end up with a situation like that in a very young one? We have different possibilities at stake. And if there is an abnormal thorax, so if you have many fusions of ribs, or if you have rib deformities, thoracic cage deformities like that, you have a high risk that you lose the patient between 5 and 10 years. So you need to approach the thorax and to provide enlargement of the thorax. And classically, this is done by a Webster procedure. So you osteomize the ribs, and you put a prosthetic rib in, and you enlarge the thorax, like it is here like it was done here. And the pleura usually disrupts because you gain volume, and you can cover it with some Gore-Tex patches. So this is done in thoracic volume depletion deformities if there is an additional thoracic deformity and pathology. For example, in this Charcot-Levine syndrome with a congenitally completely fused spine and a completely fused thorax, with a very pronounced lordosis from down to the head. So we osteomize the rib repetitively and put some distraction devices in. What if the thorax is normal and you have a normally segmented and formed spine? Classically, this has been done by standard double growing rods. We put them in submuscularly, fix them cranially and caudally, and you go back every 6 months to elongate the spine, which is a burden to the family and the patient, because if you have a 5-year-old and you need to go to puberty, you need to lengthen the patient 20 times. You have a high contamination or infection risk, and it's a burden for the family to come back to your hospital all the time. So since 2 or 3 years, we have the option to put in motorized rods, which have a magnet inside, which can be activated from outside in the outpatient clinic without any anesthesia, which prevents from having the patient back for invasive surgery. So this really led to improved quality of life for both the family and the patients. Of course, there are some limitations. The price of the implant, 10,000 Swiss francs, 1 rod. Availability of the implant, the sagittal profile has to be pretty flat to put them in, and the size of the patient. The patient needs to be big enough. One patient with a Knie syndrome, 4-year-olds, missing pedicles, severe vertebral deformities, progressive scoliosis, and you see it can be nicely corrected by this implant, and the patient comes back every 3 to 4 months, and we lengthen him in outpatient clinic. Or this young guy, a very small one with a myelomeningocele, 140-degree deformity, gibus here, recurrent ulcerations and skin lesions, but he's still small, so we performed a vertebral column resection here. We straightened the spine here, and we put some additional magic rods in to lengthen him. So in case where those magic rods are not available and the patient lives far away from your center, for example, this patient from South Italy with a myopathy, respirator dependent, it's not a case for magic. So there is another option, Schiller rods. You have some sliding screws up here and down here, and you fix the apex. So the rods which are left long slide continuously through the through the screw heads with further growth. And you see it works, but it has one downside. The apex is rotated. So this is called the crankshaft phenomenon. So with further growth, there is anterior growth, and the whole thorax is rotating to the lateral side. And another drawback of those posterior distraction procedures is that you gain correction at the beginning, about 50%, but then you undulate around the midline. So the whole system stiffens, and there is some ossification around the implant, there is some scarring. So what you get at the beginning is what you have, and it's only a coronal correction. So if you look at the transverse plane in this patient, there is an increasing rib hump. So the 3-dimensional correction is not 100%. So at some stage when it comes to puberty, you need to think about a final instrumented fusion, which is not easy because usually the spine is autofused. There is some spontaneous fusion if you have a period of 10 years where rods are crossing the spine. Often we find some additional ossification around the rods. And also the morphology of the vertebral body is changing. If you distract the spine over 10 years, you have very high vertebral bodies, and you deprive the vertebral body from axial load, so there is less periostal growth, and you have some very small vertebral bodies in the AP diameter. So the screw length is like 25 millimeters or 30 millimeters at the end, and you need to be prepared to have those implants ready to be able to fuse those spines. And usually they are very rigid. Another example of a Webster patient, and you see if you cross a thorax with a Webster bar over many years, you have spontaneous fusion. And this led us to the conclusion that we should not use those Webster bars in patients who have a normal thorax. There you need to go to the spine with traditional growing rods or magic rods. So to come to an end, we have some solution and challenges in those EOS patients. We can stimulate growth. We can control the coronal deformity better than the sagittal deformity, and we are some kind of helpless in the transverse plane. We improve the cases with thoracic insufficiency syndrome. The survival rate is much better. Quality of life has improved with the use of motorized growth. But at the end of the day, we still sacrifice function. And the vision would be to correct the deformity and to maintain the function. So the EOS strategy is casting and bracing as long as possible, and growth modulating surgery, as I told you, if the cup angle progresses to more than 60 degrees. Thank you for your attention.